The reference range for healthy individuals is 150 to 450 by 10 per liter, or approximately 7 to 21 per high-power field. 2/3 of available platelets are in circulation, while 1/3 is stored in the spleen. Their lifespan is about 8 to 12 days, though it can be shorter in certain disease states. With right stain, platelets stain gray-blue with purple granules. Platelets are found in the bone marrow, spleen, and blood vessels. In the blood vessels, platelets function in hemostasis. They originate from the same progenitor cell as the erythroid and myeloid series. Giant platelets indicate premature release from the bone marrow and result from increased demand. Immature platelets are found in the peripheral blood in certain diseases, such as acute megakaryocytic leukemia and myelodysplastic syndrome. Platelet function is dependent on platelet-secreted proteins, ATP, ADP, calcium, and platelet factors. Platelet-secreted proteins include serotonin, which stimulates vasoconstriction when vessel injury occurs, thromboxane A2, which stimulates platelet aggregation and vasoconstriction, and actomyosin, which contracts the thrombus at the end of the coagulation process. Platelet factors include PF4, which neutralizes heparin, and PF3, a platelet phospholipid needed for proper platelet function and coagulation. PF3 is needed in the production of thromboxane A2 and provides a surface for fibrin formation, limiting the hemostatic response to the site of injury. Proper platelet function involves adhesion, release of granule contents, aggregation, and clot retraction. During adhesion, platelets undergo a shape change and adhere to vascular surfaces in response to collagen exposure in the subendothelium caused by vascular injury. This process is dependent on the binding of von Willebrand factor at the GPIB receptor site and can be activated by thrombin. During aggregation, the contents of the platelet storage granules are released into the open canalicular system in response to internal cellular contraction. Fibrinogen attaches at the IIBA3A receptor of adjoining platelets, forming the initial platelet plug. Platelets release non-metabolic ADP, serotonin, and PF4. During aggregation, PF3 is released to provide the phospholipid surface needed for binding of clotting factors in secondary hemostasis. Clot retraction follows clot formation and is dependent on thrombasthenin and glycoprotein receptors ITB, R2CEF. This process restores normal blood flow to the vessel. Laboratory analysis of platelets can be both quantitative and qualitative. Quantitative analysis includes platelet numbers, which can be determined using automated instrumentation, hemocytometer counts, and blood smear estimates. Qualitative analysis includes bleeding time tests, which detect defects in adhesion, release, and aggregation. Platelet aggregation studies are used to detect platelet function abnormalities. Aggregating agents used in these studies include ADP, epinephrine, collagen, thrombin, and ristocetin. Additionally, VWF-AG, antigenic, and VWF-RCO, activity assays, are used to assess von Willebrand factor. Diseases and conditions associated with thrombocytes can significantly impact platelet function and number, leading to various clinical manifestations. Hereditary adhesion defects include conditions like von Willebrand disease and Bernard-Soulier syndrome. Let's dive into each of these. Von Willebrand disease is characterized by a lack of von Willebrand factor, which is essential for platelets to adhere to collagen in damaged vessels. It also acts as a carrier protein for coagulation factor 8C. The decreased platelet adhesion leads to mucous membrane bleeding, and the severity can vary quite a bit. In the laboratory, you would typically see a normal platelet count, prolonged bleeding time, and a decreased aggregation response to ristocetin. Additionally, there might be a variable APTT, normal PT, and decreased levels of VWF-RCO, VWF-AG, and factor 8C. It's worth noting that von Willebrand disease is the most common hereditary hemorrhagic disorder, and it follows an autosomal dominant inheritance pattern. Now let's talk about Bernard-Soulier syndrome. This condition features giant platelets, which means an increased mean platelet volume, or MPV. These platelets lack the glycoprotein IB receptor, leading to an adhesion defect because of faulty binding to von Willebrand factor. In terms of laboratory findings, you might observe a variable platelet count and platelet anisocytosis, which is an increased platelet distribution width, or PDW. You would also see a prolonged bleeding time and a decreased aggregation response to ristocetin. However, APTT and PT are usually normal, as are the levels of VWF-RCO, VWF-AG, and factor 8C. Hereditary aggregation and clot retraction defect. Glanzmann thrombasthenia is a hemorrhagic disorder seen in populations where consanguinity is prevalent. This condition is characterized by a lack of glycoprotein IUBR3A, which is the fibrinogen binding receptor. The inability of fibrinogen to bind with platelets causes an aggregation defect, while the lack of thrombasthinin or actomyosin results in a clot retraction defect. In the laboratory, this condition shows a decreased aggregation response with ADP, epinephrine, and collagen, but a normal response with ristocetin. Quantitative platelet disorders. Primary thrombocytosis is an uncontrolled malignant proliferation of platelets, not in response to thrombopoietin. It can be caused by essential thrombocythemia, polycythemia vera, and chronic myelocytic leukemia. Platelet counts can be greater than 1,000 times 10 to the power of 9 per liter. This condition is associated with either hemorrhagic or thrombotic complications. Secondary or reactive thrombocytosis is characterized by increased platelet production, usually in response to thrombopoietin. The platelet count is elevated but usually less than 1,000 times 10 to the power of 9 per liter. This can result from chronic and acute inflammatory diseases such as tuberculosis and cirrhosis, iron deficiency, rapid blood regeneration due to hemolytic anemia, and acute blood loss, exercise, prematurity, and response to drugs. Other conditions include cytotoxic drug withdrawal, postoperative state from tissue damage, and splenectomy. Thrombocytopenia is a decrease in the number of platelets, which can result from various causes. Megakaryocyte hypoproliferation can be caused by chemotherapy, marrow replacement by malignant cells, aplastic anemia, and drug and alcohol abuse. Ineffective thrombopoiesis can be due to megaloblastic anemias. Increased loss or destruction of platelets can be non-immune due to severe hemorrhage, extensive transfusion, or increased consumption seen in microangiopathic hemolytic anemias such as DIC, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura due to Adams 13 deficiency. Immune loss can be due to neonatal purpura, post-transfusion purpura, immune or idiopathic thrombocytopenic purpura, and heparin-induced thrombocytopenia. Splenic sequestration can result in up to 90% of platelets being sequestered, leading to increased destruction of damaged and normal platelets. This can occur in conditions like leukemia, lymphoma, Gaucher, and other storage diseases, cirrhosis of the liver, and sarcoidosis. Hereditary conditions include May-Heglin anomaly, Bernard-Soulier, and Wiskott-Aldrich syndromes. Falsely low platelet counts can occur due to platelet satellitosis, where platelets adhere to neutrophils when exposed to EDTA. Redrawing in sodium citrate and multiplying the obtained platelet count by 1.1 can correct this. EDA-dependent platelet agglutinins can also cause platelets to adhere to each other, and the correction is the same as for platelet satellitosis. Vessel and platelet defect bleeding symptoms include superficial bleeding, resulting in easy bruising, petechiae, ecchymoses, purpura, epistaxis, mucous membrane, or gingival bleeding.